Good evening.
Sudhir has joined. Welcome.
Good evening. Good evening.
Good evening. Good evening, Dr. Sudhir Kumar. I'm
Good
Bala here.
evening. Good evening. Good evening. Nice to see you after a long time.
Good evening, sir.
Good evening.
You're almost ready to start, I think.
Welcome to all of you for the Heart Failure Association of India Virtual Heart Failure Masterclass, the third episode of 2025. We have two exciting sessions. The first session, which we are looking forward to, is Evaluation and Management of Cardiogenic Shock in 2025 by Dr. Shashank H. Sinha, Assistant Professor of Medical Education, University of Virginia School of Medicine, Medical Director and Cardiologist, Nova Fairfax Hospital. This will be followed by a case discussion. The case presentation will be by Dr. Anil Kumar from Sri Venkateswara Institute of Medical Sciences, Tirupati, and the student panel, Dr. Balasubramaniam, Dr. Shivakumar, Dr. Prema Pasan from Madras Medical College. And the panel of distinguished examiners are Dr. Rajan Joseph Manjaran, Professor of Cardiology at Pushpagiri Institute of Medical Sciences, Tiruvalla, Dr. Sudhir Kumar N, Professor of Cardiology, former Professor of Cardiology at Government Medical College, Kottayam, Dr. J. Balachandra, Professor of Cardiology, former Professor of Cardiology at JIPMER, Pondicherry, and Dr. B. Vanajakshama, Professor of Cardiology at Sri Venkateswara Institute of Medical Sciences, Tirupati. First, we look forward to the talk by Dr. Shashank and Sinha. We are looking forward to a very exciting session. Over to Dr. Shashank.
Just 1 second. Well, it's truly an honor and privilege to be here with you all on Saturday. Thanks so much for having me. Can you hear me okay?
Yes, all good, all good. Yeah.
All right,
Good, terrific. I'm going to share my slides, and then we'll And you're now seeing,
Can you make it full screen?
yep, working on that. Full screen?
Oh, yeah, right. Excellent.
Okay, great. Excellent. Well, thanks so much for having me. I really appreciate the opportunity and privilege. It was wonderful to visit with all of you last year at HFAI at your annual Congress. So what I'd like to do over the next 15 minutes is really focus on the evaluation and management of cardiogenic shock. And my first disclosure is really this is based on US management. And so I'll welcome insights and perspectives on how you all are managing it in India. This is based on an international virtual roundtable that I had the pleasure and privilege to lead and chair with a number of mentors and experts in the field, Naveen Kapoor from Tufts, Rachna Kataria at Brown, David Morrow at the Brigham, and Rob Roswell in New York. And we subsequently came together and actually published the first concise clinical guidance for the American College of Cardiology on an expert consensus statement on the evaluation and management of cardiogenic shock that was just published last month. So I will share with you the key findings from that and delve into further detail. First, cardiogenic shock is heterogeneous, multifactorial, and dynamic. We now have obviously multiple decades of research that really has been focused on acute myocardial infarction complicated by cardiogenic shock. But as this slide shows from the Critical Care Cardiology Trials Network, nearly half of all cardiogenic shock is now non-ischemic and heart failure related in etiology. And for this reason, the Shock Academic Research Consortium recently came together and published at their classification of cardiogenic shock by etiology. So AMI can be subclassified by STEMI versus NSTEMI, heart failure shock by de novo versus acute on chronic, secondary cardiogenic shock, which may be due to arrhythmias, pericardial or valvular disease, and post-cardiotomy, which can be further subclassified. And you can see, additional modifiers due to ventricular involvement or presence or absence of cardiac arrest. But what I submit to you is that our at least understanding of the pathophysiology of cardiogenic shock has changed such that at least the canonical textbook or medical school definition of AMI cardiogenic shock due to an acute ischemic insult leading to hypotension, hypoperfusion, and congestion as a later finding is almost reversed 180 degrees in acute on chronic heart failure shock, where patients present with congestion followed by hyperperfusion and hypotension as a much later finding. And you can see how this is superimposed on other classification schema in cardiogenic shock. So number two is that it's absolutely critical to stage the shock. And the Society for Cardiovascular Angiography and Intervention first published the SCAI classification for cardiogenic shock in 2019. It was subsequently revised in 2022. And we illustrate it here in our consensus document, showing that patients can obviously both deteriorate as well as improve. And that patients who have SCAI-B shock is associated with deleterious mortality, either evidence of isolated hypotension or isolated hyperperfusion. And using physical exam, biochemical markers, or hemodynamics can be quite illustrative. Number three is that early recognition of cardiogenic shock is critical. This is data from my mentor, Naveen Kapoor, and the Cardiogenic Shock Working Group, really showing that 90% of SCAI-B patients and 70% of SCAI-C patients will escalate to a higher SCAI stage during the course of their index hospitalization. And when they do, their outcomes are typically worse. And this is illustrated nicely on the diagram on the right. So patients who present with SCAI-C have about a 20% in-hospital mortality. If they remain in SCAI-C, or perhaps better, it's about a 6% mortality. But if they go to SCAI-E, it's a 71% mortality as compared to had they shown up in SCAI-E, which would be associated with a 50% mortality. So it's very important that we remain vigilant in the evaluation of these patients and recognize when have they achieved their maximum SCAI stage. For the first time, we actually proposed both a 1-hour and a 24-hour roadmap for the acute evaluation of cardiogenic shock. And I think this is particularly helpful for those who are seeing these patients in the front line, both in the emergency room, the general wards, step-down units, and of course in the ICU. But the initial evaluation consists of both physical exam, EKG, echo, laboratory markers, including lactate, and then to risk stratify them by using the SHARC and SCAI classification as I just showed, with the initial management with vasoactive agents addressing congestion, and respiratory support, and then a time-sensitive decision about either transferring them to the catheterization laboratory, to the cardiac intensive care unit, or to what we would classify as a level 1 shock center or a tertiary quaternary care center that's capable of invasive hemodynamics, temporary support, and more. Our 24-hour roadmap actually provided a little bit more clarification, noting that perhaps a mnemonic, the suspect shock, can be used for the initial evaluation of these patients. And then subsequently, really the focus shifts to stabilization of these patients, optimization of therapy, and then personalized interventions, those who obviously need revascularization for coronary disease, but also structural interventions, ablation for those who have valvular disease or arrhythmias, assessment of exit strategies, and that's why early engagement of advanced heart failure specialists is important, and then palliative care management. Number 4 is that invasive hemodynamics may help. And this is data, again, from the Shock Working Group published in JACC Heart Failure back in 2020 in their focus issue, that really shows that complete assessment of invasive hemodynamics, especially in the sickest patients with SCI-D and SCI-E, is associated with importantly, with a reduced mortality and cardiogenic shock. And we built upon this work in a JCF publication last year, in 2023, that showed that the earlier the PA catheter is placed, it's associated with lower mortality. The Critical Care Cardiology Trials Network independently validated these findings, looking at all comers in the cardiac intensive care unit and showing that there's a reduction in mortality, particularly with mechanical support, site-related variation, and diagnosis of heart failure. And when we ask what are the parameters that are associated with reduced mortality in these patients, it's actually quite simple. It's really mean arterial pressure, but it's really the right-sided markers to allow identification of RV dysfunction or biventricular dysfunction that's actually critical in management. And based on this sort of hypothesis-generating research from observational studies, we actually are now well underway with the very first prospective multi-center randomized trial looking at PA catheters and cardiogenic shock, or the PACS trial, and we've nearly enrolled 100 patients in the study. Our goal is to target 400 patients, and we're randomizing in a 1-to-1 fashion for PA catheter within 6 hours as compared to no PA catheter or delaying after 48 hours, with the primary endpoint of in-hospital mortality. Number 5 is that end organ perfusion really is the name of the game, and you can see this is why a critical care specialist is absolutely needed from a systems-based standpoint to serially monitor these patients, including invasive hemodynamics as appropriate. And that acute non-cardiac end organ dysfunction is prevalent across etiologies, both acute on chronic heart failure, de novo heart failure, as well as AMI shock, with acute respiratory failure being the most common, but also prevalence of liver, kidney, and neurologic dysfunction. Number 6, we can't talk about cardiogenic shock without at least consideration of temporary mechanical support. And we recently celebrated the 1-year anniversary of Danger Shock that really shocked the world with the first positive RCT we've had in nearly 3 decades, showing an absolute risk reduction of 13% from 59 to 46% with the use of the microaxial flow pump, or Impella CP, in looking at 180 days all-cause mortality for these patients. But then while the number needed to treat was 8, the number needed to harm was 6. And you can see that the composite safety endpoint was nearly 4-fold higher in these patients. In doing a deeper dive, these patients were STEMI patients who had an EF less than 45%, a lactate greater than 2.5, with a systolic blood pressure less than 100, and no evidence of comatose cardiac arrest. And this really distinguished it from prior RCTs in cardiogenic shock. There still was 20% of patients who had cardiac arrest, but with a GCS greater than 8, and a mean lactate of 5.7, and a mean LVEF of 24. There was very little crossover between groups, and you can see what the reduction was, as noted earlier, in hospital mortality. But note that there was a 22% risk of moderate or severe bleeding, which was nearly 2-fold higher in the intervention arm, as well as a 6-fold increased risk in limb ischemia, as well as a 2-fold increased risk in renal replacement therapy. So based on largely these results, the 2025 ACC-AHA guidelines have now published a 2A recommendation that for these selected patients who meet these inclusion criteria from Danger Shock, that placement of a microaxial flow pump is actually reasonable, a class 2A indication to reduce death in these patients. And that for routine use of either intra-aortic balloon pump or VA ECMO, there is potentially harm, and we're given a class 3 recommendation. You all are quite familiar with the various technologies that are used to support either the right or left or biventricular support for these patients. And so we, for the first time, actually incorporated those algorithms, many published by shock teams around the world, that really encapsulate how we should risk stratify these patients for at least the initial support, based on their sky stages and based on their congestive profiles. We specifically highlighted that Impella CP was the only randomized evidence in AMI shock based on the danger results. Trials with intra-aortic balloon pump were neutral, and that was also identified. And then the rest of this is really based on best practice or observational study and merits further randomized investigation. The same was true for heart failure shock, as you can see here. And really, this entire chart is based on observational data at best, and more randomized data are forthcoming. However, when we look at this in the real world population, in let's say the Critical Care Cardiology Trials Network, we actually found that among 20,000 patients, 757 of whom had STEMI shock, really only 5% of all CS admissions were danger shock eligible based on the inclusion and exclusion criteria. But that really does constitute about a third of all STEMIs. Now, hot off the press, published by our Italian colleagues, was the ALT-SHOCK 2 trial, which unfortunately was a negative trial, stopped early for futility. But it was 101 patients looking at heart failure shock across Sky B to D Sky stages, looking at the primary endpoint of survival or successful bridge to LVAD or heart transplant at 60 days. And while it was a negative trial, many have argued that perhaps now it's time to give it immediately a Class 3B indication, and I'll look forward to our discussion here. But I think that it may be a little bit premature in throwing the baby out with the bathwater. There were a number of challenges with the study design and with recruitment. And perhaps the accompanying editorial by Dr. Proudfoot, Moeller, and colleagues really suggests how we should proceed, which is a bold step towards international collaboration through efficient evidence generation in other spheres and looking at large-scale pragmatic clinical trials. Number 7, it's important to reassess, and then reassess. And that's because, again, data from the shock working group that was published at the ESC Congress last year and simultaneously in JACC really has showed that patients with Sky B and Sky C deteriorate at similar degrees to Sky D or worse in the first 24 hours. But as you can see from the Sankey diagram, after that, there's not really further risk stratification. And so that first 24 hours really is important. And now there's even more compelling data suggesting that it's really the first 6 hours that may be even more critical. And at least in the US, we're now sort of classifying this by level 3, level 2, and level 1 centers. Level 3 being centers capable of just the diagnosis but don't have PCI capabilities or temporary support. Level 2 having some capabilities for at least STEMI and PCI with some limited temporary mechanical support options. And level 1 capable of all aspects of shock care, including advanced therapies such as LVAD and heart transplantation. So I think that this slide summarizes it nicely from my friend and colleague at Inova, Vanessa Bloomer, and I was privileged to be a co-author on this AHA statement, that early identification is critical, then stabilization, and then a really team-based interdisciplinary assessment to determine the care pathway, the goals of management, and to determine which pathways prioritizing recovery first, and then advanced therapies for heart failure, and hospice really as a last resort. Number 8 is that care of shock is a team-based sport. We at Inova were among the first to publish that shock teams are associated with improved survival in patients with cardiogenic shock. Stavros Strakos and his team at University of Utah published similar findings in Circulation a few months later. And then Dr. Lee and her colleagues published this work out of University of Ottawa in CJC Open in 2020. But it really wasn't until Alex Popoulos, Ben Kenigsberg, and colleagues from the Critical Care Cardiology Trials Network published showing that a multi-center analysis in 10 out of 24 centers with shock teams, we were associated with reduced mortality in the CICU with these patients, associated with increased PA catheter use and increased advanced MCS beyond an intra-aortic balloon pump. And the reason perhaps why shock teams are helpful is that there's a lot of information that needs to be elucidated in a time-sensitive fashion to match the right therapy to the right patient at the right place and at the right time across the features of shock itself, patient selection, therapeutic considerations, and then of course systems of care. Number 9, prevention, recognition, and management of complications of therapy is key. As you can see, there are a number of both cardiovascular and importantly non-cardiovascular symptoms that are implicated either because of the shock itself or because of device-based therapies employed in the management of these patients. And it's important to pay attention to these complications, not only for the initial management, but also for the long-term morbidity. And importantly, complications do increase with the number of devices and with time. And that includes not just access-related complications, circulatory bleeding and thrombotic, but acute kidney injury, as well as infectious-related complications, and then important ICU-related complications like critical illness, neuropathy, myopathy, cognitive impairment, and so forth. And number 10, palliative care options are really essential. And hand in hand with that is really early engagement of the advanced heart failure team. It's important to reassess for de-escalation on a daily basis. And if the patient is not able to wean, understanding why and consulting advanced heart failure early to see what our strategy to bridge them to either durable mechanical support or heart transplant or recovery is possible. And if not, then palliative care is essential for these patients. So with that, I leave you with my key takeaways. And thank you very much for your time and attention, and look forward to our Q&A.
Thank you, Dr. Shashank, for a brilliant exposition on the aspects of cardiogenic shock management in 2025. I'm sure there will be a lot of questions, but you said something about IABP. Most of us in India, probably that may be the only available support system that we have. Except in the higher centers, we don't have mechanical support, other forms of mechanical support. So I think IABP might still be may have some role to play in our setting, basically in India. The other point that you highlighted was extremely important. That is, end-organ perfusion remains the most key to the management of cardiogenic shock. And again, you emphasize on the team approach to management of cardiogenic shock. And any questions or comments from the distinguished panel, Dr. Sudhir, Kamal?
May I, Dr. Shashank? There was a beautiful overview. In the Indian context, for many of us, the VA ECMO would be more accessible compared to Impella and devices. So where would you place the role of VA ECMO, especially in potentially salvageable conditions like myocarditis or peripartum cardiomyopathy, which we commonly encounter?
Yeah, no, great questions. And that's where we're going to really steer away from randomized trials, right? You're all familiar with sort of the results of ECMO CS as well as ECLS shock, that is the largest study that Holger Thiel did that was neutral. But that was really looking at AMI shock only and had, importantly, 77% of patients who had cardiac arrest and required CPR. And so that's a very sick population that has both cardiogenic shock as well as cardiac arrest with sort of unclear neurologic status. I do think that VA ECMO has a very important role, particularly in BiV shock, ideally in SCAI stage D, but also in SCAI E as salvage therapies for the indications you noted, right? Peripartum, myocarditis, but a number of other etiologies, including acute on chronic heart failure shock. At least in the States and in many places in Europe, and I'd welcome your thoughts from the subcontinent's perspective, we are able to bridge those patients then to transplant or to durable LVAD in some cases. So I very much still think that these devices, including the intra-aortic balloon pump, continue to play a key role. The Achilles heel of many of these clinical trials is that it's all about patient selection. And it's very hard to truly identify the exact patient population a priori that's likely to benefit, even though we see it day to day in our clinical practice.
Dr. Shashank, this is Dr. Balachandra from JIPMA, Pondicherry. You rightly mentioned that early placement of the PA catheter is perhaps coming back. Actually, we were one of the first in the country to do hemodynamic monitoring in cardiogenic shock with this Swan Ganz. But after 2000, it went out of vogue, and people started telling that it has more complications than usefulness. In true cardiogenic shock, it doesn't help. But you have brought it back, and I think it's a very good thing. The other thing which I wanted to stress is on ventilated patients, a simple measurement of end-tidal CO2 will give us a very good indicator for the perfusion. What do you think about that?
Yeah, love both of those comments. So one, thank you for reviving the Swan. I think both Jeremy Swan and Peter Ganz would be very happy about that. It's unfortunate that because of the ESCAPE trial, among others, the support trial as well, PA catheter use really significantly declined. And just because I recognize there are a number of trainees on this call as well, to review the ESCAPE trial, published in JAMA in 2005, 433 patients, 26 centers. It really was looking at a diagnostic instrument and seeing how it improved outcomes for 180 days alive outside of the hospital. So not surprisingly, it had a negative result. But what was never published, and I'm happy to kind of confide and share in this forum, is that if a subgroup analysis of the top 6 or 7 centers with the most volume and the most experience, it was actually a positive study. They obviously, for a variety of reasons, couldn't publish and share that result, but certainly the DSMB was aware of it. And so partly for that reason, and I guess to really amplify the point, fewer than 5% of patients enrolled in that study met contemporary criteria for cardiogenic shock. So it was a study of advanced heart failure, but definitely not of cardiogenic shock patients, at least SCAI C through E as we would currently define them. So for those reasons, there was a number of registry-based results, as you saw, shared from the Shock Working Group and the Critical Care Cardiology Trials Network, that have motivated us to do this randomized trial, and we'll see what we'll find. I will share, this is part of the challenge in doing randomized trials, is because you either believe in the swan or you don't, there's not as much equipoise at many centers to actually randomize. They either say like, no, I'm going to put it in, or no, I won't put it in. And this is precisely one of the controversies and challenges in modern medicine. And so hopefully we will be able to complete the trial and share what those results are. As I mentioned, we're about 100 out of 400 so far. So those results should be forthcoming in a couple of years. And forgive me, that your second point was regarding end-tidal CO2, correct? I do think these simple parameters are helpful in at least signaling that something is wrong and merits further attention. Whatever heuristics, similarly using sort of pulse pressure, but I think being able to evaluate our patients and recognize that cardiogenic shock extends beyond the heart, and that multi-organ dysfunction is really what the Achilles heel and common cause of death for these patients is important to recognize.
Dr. Shashank, there is a question from the chat box, Dr. Harish. Which scoring system should be considered when treating patients with cardiogenic shock? Either cardio shock score or IABP shock to risk score, which has more specificity or sensitivity?
Yeah, it's a really good question, and believe it or not, there have actually been 100 different scores, over 3 or 4 decades that have been developed for cardiogenic shock, all of which have their advantages and as well as their disadvantages. So unfortunately, at this time, and we were we deliberated extensively, as you might imagine, among our consensus group about whether to recommend a specific scoring system, and we ultimately decided not to. That being said, at ANOVA, we use the ANOVA shock score, which is 6 parameters and seems to be highly correlated with at least 30-day mortality. And it's really not what your lactate or your cardiac power output or your pulmonary artery pulsatility index is at admission. It's what it is at 24 hours or 36 hours that seems to be more prognostic. And that's why we really focused on this concept of the golden day to be helpful. But for further reading here, I would highly encourage you to take a look at Dr. Kalra and colleagues. They published a state-of-the-art review summarizing all the scoring systems in JCF, admittedly my journal, Journal of Cardiac Failure, back in 2021.
Any further comments?
So just a question from my side, sir. I am Dr. Ishwar Kumar, MMC postgraduate. In case of an inferior wall MI with RVMI, there is a VSR at the basal level. Which do you think will be the ideal inotrope to start, and which you think will be the MCS that has to be upfront used, sir? Inferior wall MI, RVMI with VSR.
Yeah, great question. I think, so if I'm understanding correctly, acute inferior MI with a ventricular septal rupture.
Yes.
Is that correct?
Yes, sir.
Leading to cardiogenic shock. I think, at least in the States, we would probably go straight to either ECMO or some configuration to best support it. The challenge with ventricular septal rupture, as you know, is that due to that liquefaction of necrosis, it is very hard to have any immediate therapy to stabilize the patient. So really what you're trying to do is buy time to salvage the patient thereafter and stabilize them for surgery. In terms of inotrope, really the goal here is to minimize further the supply demand mismatch, right, in terms of myocardial oxygen consumption. And so I don't know that we actually have the studies to corroborate whether that's monone or dobutamine. Both seem deleterious to a certain extent, but I think you need to support the patient as best as possible. And so we routinely use norepinephrine actually as a first line sort of vasoactive agent for shock, sort of irrespective of the etiology. But admittedly, all of that work is really based on case reports and case series. There's no randomized data to really highlight it. There have been some AHA scientific statements on the topic, but again, that's based on expert consensus only.
Thank you. May I call Dr. Chopra? Dr. Chopra for his comments. Any comment?
I just joined in. Actually, I'm in Coimbatore.
Yeah.
I came for a meeting with Abraham. So I'm sorry, I missed most of it. So I think you can carry on.
Yeah,
Good to see you, Dr. Chopra.
Venu sir, can I ask a question?
Sergeant, please go ahead.
Yeah, sir, in your experience, would you recommend early renal replacement therapy for patients who go into cardiorenal? Because most of our patients, they ultimately go through that route.
Yeah, it's interesting, right? So if we look at the Danger Shock trial, what it showed us was that 42% of patients in the intervention arm, as compared to 27% in the standard of care arm, required some renal replacement therapy during the course of that study. What the long-term outcomes have shown that at 6 months, all survivors were actually off dialysis. So perhaps, even though they have significant complications early on, if you support them long enough, there may be some recovery. As we know, the kidneys are easily offended and take long to forgive. So I think with that in mind, at least our strategy has been to really escalate as a last resort to renal replacement therapy because of the various complications that do potentially do occur, and then the need for potentially dual organ and transplantation, right? If it is the patient is able to actually maintain euvolemia with high dose loop diuretics with thiazide augmentation, that would seem to be preferred. But so we have not adopted an approach of at least early renal replacement therapy.
Thank you.
I think we had a very wonderful session on cardiogenic shock and management. Thank you so much, Professor Shashank, for a wonderful talk.
Thank you very much. I hope you all have a wonderful evening and best wishes.
Thank you.
Thank you for having me.
We'll go to the next part of the program, that is a case presentation. Over to the panel of examiners, Dr. Sudhir Kumar, Dr. Ram Manjuran, Dr. Balachandran, and Dr. Marjakshama to take the program forward. And may I invite Dr. Anil Kumar, who will be presenting the case. Over to Dr. Anil Kumar. To the panel of examiners, sorry, to the panel of examiners.
Good evening, Venu. Am I audible?
Very well, sir.
Am I audible?
Yeah, you are audible.
Yeah.
All examiners.
Which is the presenting institute?
Sri Venkateswara Institute of Medical Science, Tirupati.
Tirupati. And discussing institute?
Madras Medical College.
Which one?
Madras Medical College, 3 PGs, Dr. Balasubramanian, Dr. Shivakumar, and Dr. Prima Pasha. 3 PGs.
Presenter from Tirupati is Anil Kumar.
Yes, Dr. Anil Kumar, he is there. Okay.
So I think good evening to everybody. Dr. Anil Kumar, can you? Where is Sudhir Kumar? I'm not able to see him.
He's there, sir.
I'm here, sir. I'm
okay.
Bala,
Okay. So
welcome
I think
Dr. Marjakshama also, because she joined a little late.
Namaste, sir.
Thank you. Yes.
okay, Anil Kumar, please start.
Sir, good evening, sir.
Good evening, good evening.
Good evening, sir. Myself, K. Anil Kumar, finally postgraduate DM Cardiology, Sri Venkateswara Institute of Medical Sciences, sir. Today I am presenting a case of 19-year-old male patient hailing from Anantapur, Hindu religion, education 7th class and agricultural laborer belonging to low socioeconomic status. Informant was patient and reliability was good. Came with chief complaints of breathlessness since 3 years, fatigue since 3 years, and palpitation since 1 year. History of presenting illness. Patient was apparently normal 3 years back. Later, he developed breathlessness, which was insidious in onset and gradually progressive. Initially, he was able to climb 2 flights of stairs, and breathlessness progressed and worsened over the last 6 months. And he started to feel breathlessness even while doing day-to-day activities and on climbing 1 flight of stairs. There is no history of paroxysmal nocturnal dyspnea and orthopnea. There is no history of cough with expectation. There is no history of seasonal variations and audible wheeze. Patient also had complaint of easy fatiguability since 3 years, which was NYHA class 3. Patient had history of palpitations on exertion since 1 year, which he describes them as fast beating of heart and are regular in nature and gradually progressive. Initially, he had palpitations on walking 1 kilometer and climbing 2 flights of stairs, which were relieved on taking rest for 10 to 15 minutes. His symptoms worsened over the last 6 months, and he was unable to walk 500 meters or 1 flight of stairs without discomfort or palpitations. For the last 6 months, the frequency of palpitations were increased. There is no history of post-palpitation diuresis. There is no history of lightheadedness, syncope during the episode. About 2 months back, he went to an outside private hospital where he was diagnosed to have heart disease and was treated with oral medications, and the symptoms improved. Patient stopped taking medication since 1 month, and he started feeling breathlessness since the last 10 days on climbing 1 flight of stairs. There is no history of chest pain. There is no history of swelling of both lower limbs. There is no history of hoarseness of voice. There is no history of difficulty in swallowing. There is no history of slurring of speech, limb weakness, diminished vision. No history of recent fever, joint pains. There is no history of cyanosis, squatting spells. There is no history of bleeding manifestations, and there is no history of decreased urine output. Coming to the past history, at the age of 12 years, patient had history of fever associated with joint pains involving ankle, knee, elbow, which was migratory in nature, not associated with swelling, and were resolved after taking medications. Patient had history of breathlessness during that episode, which was NYHA class 2. There is no history of rash or involuntary movements or abnormal behavior during that episode. He was advised to take oral medications which increased urine formation and injections once in every 3 weeks after the discharge for a period of 10 years, which he took for 1 year and then stopped. There is no history of pulmonary tuberculosis in the past. Coming to the family history, he was born out of non-consanguineous marriage. He was second born out of three children. All his siblings are healthy and alive. No similar complaints in the family members, and no history of sudden cardiac deaths. Coming to the personal history, he is unmarried, takes non-vegetarian diet. His sleep and appetite were normal. His bladder and bowel habits were regular. There is no history of smoking, alcohol, or drug abuse. Summary: the 19-year-old male with low socioeconomic status with history of progressive exertional breathlessness and exertional palpitations, easy fatiguability with past history of rheumatic fever, who advised oral medications and injections for a period of 10 years during a hospital admission at the age of 12 years, which he stopped after taking for 1 year.
Stop here. Please come
No,
back.
don't come to the diagnosis. I think a few comments about the story. I think you have given a very elaborate story. Sometimes in the DM examination, some of the points can be actually grouped together and story can be slightly brought down. But you have given a very elaborate story and you are summing up also, I think, reasonably all right.
Yes, actually, I agree with Dr. Manjunath, because at the DM level, you should not give such an elaborate history. Like, for example, if you are very sure about the history, about rheumatic fever, etc., there's no point in mentioning squatting or cyanotic spells or other things. So you must group your history in such a way that it is short and it is, it conveys the necessary and another thing I would like to say is that always you can present in two ways. One is you present as you have presented nicely, go back to past history, or start from the time he had rheumatic fever history, and then says when did he develop a problem. This is also acceptable in DM examination because that gives a complete, picture of the patient.
So in the DM examination, if you can intelligently summarize the story, that itself gives a good impression on the examiners. So rather than elaborate unnecessary descriptions, you can bring in points which are more relevant, more important in the history part. But your summary was really good. I thought that was a good summing up of the story. So shall we ask the discussing?
Shall I make some comments, sir?
Please, please.
Before going to the, can you start with the first slide, please? Now, what are the things which you can modify? That's our aim. Okay, this is fine. Breathlessness and fatigue for the exertional breathlessness and fatigue for 3 years. You can say that the patient has dyspnea, fatigue, and palpitation on exertion progressing from 2 to 3 over the last 3 years. That could be the way I present history. Next slide, please. Next slide, please. Now, that's again, as sirs have said, you need not go into the details. Next, certain areas where you are likely to be. Next slide, please. Next slide, please. EC fatiguity, you have to proceed because you have 3 symptoms. EC fatiguity, you have to discuss a little more detail. What is the function? At that time, you have to say that there is no syncope or pre-syncope. Well, that's an important symptom, EC fatiguity. So that we'll discuss. Regarding the palpitation, you need not discuss in detail. The palpitation also was brought on exertion, regular and relieved by rest. The usual thing is no step post-palpitation diuresis. These are the areas where we will ask questions. On post-palpitation diuresis, I may not ask my questions now because that we'll discuss later. Diuresis occurs during palpitation if it is prolonged because the mechanism is not in exertional palpitation. That classically occurs in a tachyarrhythmia where there is an atrial contraction during systole, where there will be phasic contraction of the phasic elevation of the atrial pressures, resulting in release of the peptides, all those things. So it is not post-palpitation. This always I've heard from students saying post-palpitation. That you mentioned only if you think it is an arrhythmic palpitation. Okay. If you think that palpitation is arrhythmic, you have to say there was no history of diuresis, all those things about all those things. And don't say that he went to an outside hospital where he was evaluated, diagnosed of heart disease, and put on medication which included diuretics and parenteral penicillin, rather than a drug which produces urine output. Next slide, please. Next slide, please. Now, here the problem comes. Okay. Here you can, as sir said, at the age of 12 years, the patient had fever with polyarthralgia and he was diagnosed with rheumatic fever. However, he did not have definite evidence of cardiac. Okay, he had breathlessness, but you have to tell that he had, during that episode, he was in NYHA2. That's a very difficult thing. When a patient is having polyarthralgia, he is unlikely to be in class 2. He will be taking rest. So that you should be careful. What we want to know is whether the patient had clinical evidence of carditis. Like you have to say the patient did not have orthopnea, breathlessness, or features of carditis like pericarditis or heart failure. That is why Balendran sir has said you can draw conclusions at DM level. Okay. Then next will be next. He was advised. Don't say that he was advised to take penicillin prophylaxis for 10 years, which he discontinued. Next slide. There is no evidence. No step tuberculosis at that point is not relevant. People may ask you, why did you ask for history of tuberculosis in the past? Because it is not relevant. Certain things can be avoided. Next slide, please. Next slide, next slide. Okay, next slide. Then you are talking about cyanosis and spells, which may not be very relevant now. You are inviting questions from us. And a 17-year-old boy, you have got the history from the patient. Very unlikely that doctors might have gone into the details of spells. Very unlikely, and he is unlikely to recollect that. These are my comments. So I may present like this: a 17-year-old boy who is working in the farm with a history of rheumatic fever in the childhood has presented with progressive excessive dyspnea, palpitation, and fatigue, progressing from class 2 to 3 without recurrence of rheumatic fever or any other major complication. That will be my summary. Thank you.
Shall we ask the?
Can I ask one question, Dr. Bajuran? We just had a lecture on escape trial. What are the 2 main symptoms in the escape trial that will be relevant here? There are 2 escape trial. You must have read the escape trial. It's largely clinical. We are happy that such a clinical trial came into existence after a long time. Of course, it was a PA catheter. But what was the two symptoms you look for to say there is heart failure? The two symptoms are, what are they? Orthopnea, which you said is not there, and edema. Combined, it's called orthoedema, which is not there. 3 pillows of use of the patient will tell you that the patient is having a valvular heart disease with heart failure. Okay.
Well, you ask the Madras Medical College students to discuss the story, because we should give them freedom to discuss the story. Who is going? Is it Balasubramanian? What is the name of the student who is discussing? Is it Balasubramanian?
All three of you, please, Prema Person, Balasubramanian, Shivkumar, please turn your videos on and please answer the questions.
Discuss the story.
Sir, myself, Dr. Shivkumar, sir, a final year postgraduate.
Okay.
Here is a boy who is a 19-year-old male, and he had a progressive dyspnea on exertion, and there is an exertional palpitation and EC fatigability.
So say what I would like to discuss slightly differently. Rather than repeating whatever the previous presenter has given, I think you should draw conclusions. I would first start from the scratch. Whether which is
from the symptomatology, it is most probably the cardiac system that is involved, sir, with the combination of three
cardiovascular disease. Why are you saying it's cardiovascular disease?
Exertional dyspnea with the palpitation, with the fatigue, and these three combination put together, it is more pointing towards cardiovascular.
And also in the past history, there is a history of rheumatic fever, which can affect the valves of the heart. Okay, right. Second question I usually ask is which is the left side disease, right side disease, both side disease.
Sir, actually, we don't have a PND in this case, so we can't able to localize it as to the left-sided alone. But from the history of only 3 years duration, it is most probably there can be a predominant regurgitation lesion, then the stenotic lesion, and it can be a LV outflow regurgitation, more common than the LV inflow regurgitation, sir.
Rheumatic fever. What is the most frequently and almost always affected valve?
It's a mitral valve that is almost
the mitral valve,
most commonly affected.
Mitral valve. And in the mitral valve, which is the commonest lesion? Is it a stenotic lesion or a regurgitation lesion?
In times of acute rheumatic fever, it is regurgitation that is more common, sir.
No, only my regurgitation lesion. The acute rheumatic fever, the classical lesion that happens is mitral regurgitation, not stenosis.
Mitral regurgitation.
And a small percentage of patients, especially those who have got rheumatic fever later in life, maybe in the second decade or later in the second decade, they can have associated, sometimes especially in males, aortic valve involvement, and about 20% of the patients with valvular involvement, they can have some degree of aortic regurgitation. But mitral valve is almost always affected in acute rheumatic fever, and the lesion is mitral regurgitation. Mitral stenosis and all occur quite late. So this patient most likely has got a left-sided disease. Why? We can conclude that this is a left-sided problem because what are the why do you think that this could be a left-sided disease?
There is dyspnea on exertion, but the fatigability is also there. And
what is meant by fatigability? Why do you say that fatigability is a left-sided symptom?
So because of decreased forward flow.
In the case, reduced cardiac output.
Yes.
So fatigability is a symptom of reduced cardiac output.
Reduced cardiac output.
This can be, of course, more often it is a left-sided cardiac output that is affected. But even the right-sided cardiac output, if it is affected, then the left-sided cardiac output also will fall. So you can't be certain from the fatigability that whether it's a right-sided or left-sided disease. But if the patient is having significant breathlessness, so that could be most likely a symptom of
left-sided
heart disease. Even though sometimes you can have breathlessness as an important symptom in right-sided heart disease, especially primary pulmonary arterial hypertension. Most of them present with significant exertional breathlessness. And there are many reasons to explain why there is breathlessness of the right side of the heart involvement. We are not going to the details. Okay. then what else can you draw a conclusion?
You said that aortic valvular regurgitation is likely or mitral valvular regurgitation. What is the symptom which will distinguish between an aortic valvular regurgitation or a mitral valvular regurgitation? Symptom. What symptom will distinguish between the two?
They're usually in mitral regurgitation, EC fatigability.
Yes, so EC
will be there.
fatigability is occurs. Why it doesn't occur
Yes.
in aortic valve regurgitation usually till late?
Sir, in aortic regurgitation, usually it will be an high cardiac output state.
Not
And
aortic.
also,
Yes.
and also, if you look at the hemodynamics of exercise, can you just explain the hemodynamic effect of exercise on aortic regurgitation, mitral regurgitation? What are the hemodynamic effects of exercise on these two lesions?
The exercise will cause an increased.
When you exercise,
the exercise will cause an increased systemic vascular resistance. So
exercise will cause an increase in systemic vascular resistance.
It's like, sorry, there is an increase in sympathetic drive. So
you cannot deviate from that SVR, systemic vascular resistance. You cannot deviate from that. That's a crutch.
What happens is, when you exercise, what happens to systemic? If there is an increase in systemic vascular resistance,
it decreases. It decreases.
Heart rate will be increased, sir. Systemic
There is an
vascular
increase
resistance will be decreased.
Increase in heart rate.
Increase in heart rate, sir. Decreased systemic vascular resistance.
What happens to systolic blood pressure? What happens to systolic blood pressure? When you exercise, what happens to systolic blood pressure?
Increase.
No, this is a very fundamental question. What happens to systolic blood pressure when you exercise? Decrease, increase, stable, remain the same.
It increases, sir.
Systolic blood pressure definitely increases. It's significant. Yes. What happens to diastolic blood pressure?
Since systemic vascular resistance is decreasing, diastolic BP will be decreasing, sir.
Yes. So now we have to look at the hemodynamic effect of these hemodynamic changes on these two lesions. Let's look at increase in heart rate. What happens to AR? What happens to MR?
Sir, when there is increase in heart rate, the diastolic time will be reduced, sir. So in regurgitation and acute aortic regurgitation, as the diastolic time increases, the amount of regurgitation will come down.
Okay. So the increase in heart rate will reduce aortic regurgitation, but what happens to mitral regurgitation?
So mitral regurgitation, the regurgitation will increase and it will cause increase in the symptoms. It will increase the backward flow.
That's enough. If there is an increase in systolic blood pressure, what is the effect?
Sir, mitral regurgitation will worsen, sir.
Mitral regurgitation will increase, and what about aortic regurgitation?
Aortic regurgitation will
decrease.
No effect. There may not be any effect on aortic regurgitation. When there is a reduce in the peripheral resistance and diastolic blood pressure comes down, what is the effect on mitral regurgitation? What is the effect on aortic regurgitation?
Sir, when the blood pressure comes down, mitral regurgitation will improve, sir.
Sir, when
there will be decrease in the regurgitation.
May not have any significant effect. Diastolic blood pressure may not affect the mitral regurgitation. What will happen to aortic regurgitation?
When peripheral vascular resistance is increasing, sir, aortic regurgitation
decreases.
The peripheral resistance comes down, the aortic regurgitation comes down. So if you look at the exercise physiology, it actually favors aortic regurgitation. Aortic regurgitation patients, all the hemodynamic changes of exercise are favoring aortic regurgitation, and many times patients with aortic regurgitation can tolerate exercise extremely well. But it is mitral regurgitation, it is different. And also mitral regurgitation can actually, with exercise, they can actually, can be an acute rise on the left atrial pressure, and that can precipitate symptoms of breathlessness. So the symptom of breathlessness can come up early in a mitral regurgitation compared to aortic regurgitation. And finally, patients with mitral regurgitation can develop an arrhythmia which can deteriorate. What is arrhythmia?
regurgitation,
Most commonly atrial fibrillation.
Atrial fibrillation. Patients with mitral regurgitation can develop atrial fibrillation, while aortic regurgitation patients do not develop atrial fibrillation. And in aortic regurgitation patients, the LV is not in direct contact with the pulmonary veins, and hence pulmonary congestion, pulmonary edema is a late phenomenon. While in mitral regurgitation, left atrium is in direct contact with the pulmonary veins, and the patient can develop pulmonary congestion and pulmonary symptom of breathlessness. So, if you look at the symptom in this patient, which lesion should you favor?
Sir, initial differential will be inflow regurgitation. Mitral regurgitation will be the first differential.
Patient has exertional breathlessness, so I would definitely favor mitral regurgitation rather than aortic regurgitation. What about mitral stenosis?
Sir, from the history, there was no significant specific history of PND or orthopnea. In absence of PND,
PND would have been a very strong point in favor of mitral stenosis. But since exertional breathlessness is an important symptom, I would like to think of mitral stenosis also. May not be very severe, but it may be mild or moderate.
Mild, yes, sir.
So in which condition you have tight mitral stenosis but no PND? In mitral stenosis, no PND, orthopnea.
Or a few conditions. We can ask 3 or 4 conditions where there can be tight mitral stenosis and no PND.
Then
very good.
Yes.
When severe pulmonary hypertension develops and RV failure.
Okay, very good.
Yes.
What else?
Tricuspid valve?
Yeah. Yes. Anything wrong with the tricuspid valve?
LA getting decompressed? Tricuspid valve disease.
Tricuspid stenosis.
Or regurgitation.
I
will start
when
from that level.
When associated AS is there.
Yeah, ASD. AS, the symptom will worsen. ASD decompress. Whenever the LA is decompressed because of hypovolemia, atrial septal defect, pulmonary, anything which reduces the forward output from the right ventricle, like pulmonary hypertension, RV failure, tricuspid valve disease, pericardial disease, or right atrial masses. Okay, I would like to continue the discussion. Rheumatic mitral valve disease, this patient has developed symptoms very early. That is, by 15 years, 14 years, the patient has become symptomatic. That means the rheumatic fever was severe or the patient had recurrent rheumatic fever. Okay, that means you have to expect a severe involvement of the cardiac system during rheumatic fever. As he became symptomatic by 14 years. So you may have to suspect multivalvular lesion also. Mitral valve is the commonest, especially when the patient presents with symptom of breathlessness. Because LA pressure, the closest valve is mitral valve. And the commonest is a combined lesion, of which you can say it is MR dominant, rather than saying pure MR. But because this patient developed cardiac symptoms by the age of 14 years, it indicates that when was the rheumatic fever at what age? 10 years.
12 years.
12 years.
12 years. 12 years rheumatic fever, and within 3 years, the patient has gone in for symptomatic valvular heart disease. So it has been severe disease, and you have to anticipate multivalvular involvement. That is one. Second, mitral valve disease is more common, and combination and dominant MR may be the same. Regarding the hemodynamics, it is not very simple in mitral regurgitation. The blood pressure rise is why the blood pressure rises. It rises more in AR. Okay, as you have said, it rises more in AR. But the rise in blood pressure is because of the increase in stroke volume. So when the systemic vascular resistance decreases with exercise, the stroke volume also increases. But you have to think of other factors why the patient is becoming symptomatic. When there is tachycardia, what happened to the cardiac diastole? It comes down. So what happened to the LA to LV emptying? It comes down. So the LA volume retains. And there is increase in the venous return also. So there are multiple factors which contribute to the symptom of breathlessness. So what happens is the LA pressure is going up, the forward stroke volume is not increasing. That is the reason why Balendra sir has said that this patient's symptom of fatigue among the valvular disease, it is without other symptoms of AS, it indicates that either the patient has, if it is valvular lesion MR, or the patient has developed pulmonary arterial hypertension, that is the reason why the patient doesn't have PAH. So you can say that this patient is having pulmonary venous congestion, the cardiac output is not increasing adequately with exercise, and there are no clinical signs to suggest systemic venous congestion. Okay, that is number one thing. My question is on rheumatic fever. Are you happy with the diagnosis of rheumatic fever with the available data? I agree that you may not get, but with the available data, will you diagnose rheumatic fever or not? Suppose this patient has come to you now with these symptoms, will you diagnose rheumatic fever? Does it satisfy the criteria? Yes, fast. In rheumatic fever, you cannot take time.
I think you have to go to the.
Suppose this patient has come to you with the same symptoms, 1 week history of polyarthralgia, whatever the symptoms, they had a fever. Does it satisfy the criteria for rheumatic fever? Well, you can ask me one question. Sir, I think it is rheumatic fever, provided you give me the data. What is the data you want? What is the, you want a clue? If there is a clue, there is no problem. Now, what is the modification which has come over the years on diagnosis of rheumatic fever, and what are the situations where the criteria has been modified a little bit? Do you know about high risk versus low risk? Pardon? High risk versus low risk. Polyarthralgia is a major risk factor in low risk cases. Monoarthritis is a major criteria. So you should have asked me, what is the risk status of this patient? Risk for rheumatic fever. Do you know that? Low risk, what is the criteria for low risk? Because you cannot get away from rheumatic fever questions. That is unfortunate because their disease is relatively coming down. Do you know the criteria for low risk and high risk?
Yes.
In school age, between the age of 5 to 15 years, if the rheumatic fever incidence is less than 1 lakh per year. If it is less than 1 lakh, it is low risk. Or overall incidence of rheumatic heart disease is less than 1 in 1,000 per year. 1 in 1,000 per year. So that you should know. So if you have asked me, sir, this is low risk or high risk case. Okay. This, as per that criteria, we don't know, but we have said it is from a low socioeconomic strata. So likely to be a high risk. So these are the questions you are likely to face. So basically, rheumatic fever, agree if it is from a high risk case. Second, the interval between rheumatic fever and the onset of cardiac symptoms is relatively short. That indicates the carditis was severe, and invariably the patient should have mitral regurgitation, and you have to suspect development of other valvular lesions also. The hemodynamics of AR we have discussed, but MR I would like to contribute that the duration of diastole is shortened, the time for LA to LV emptying or the LV inflow is shortened, so blood retains in the LA, that leads to high LA pressure. The systolic blood pressure doesn't rise significantly in MR because the stroke volume is not increasing. Stroke volume is not increasing despite fall in SVR. Okay.
And we now go to the physical examination.
Yes.
I'm not trying to excite to bring in some discussion because as Sudhayama rightly pointed out, there is a short period by which the patient started developing significant symptoms. From the story of the patient, it does not appear that the patient had severe acute rheumatic fever because during the episode, patient did not have any significant symptoms which can be attributed to cardiac malfunction. So if that is the case, do you think that patient might have had a primary myocardial disease also, which deteriorated with the involvement of the rheumatic fever? Because of the DM discussion, we should think of all possibilities. Do you think that we have to keep in mind a possibility of a myocardial problem which actually deteriorated when the patient started developing valvular regurgitation?
Actually, he has given some differential diagnosis. We can look at it in the slide.
Okay.
Fine.
Okay.
That's fine.
Yeah.
Based on summary, the first differential will be the valvular heart disease, left side more than right side. The lesion may be regurgitant more than stenotic, involving the mitral valve. And the second differential will be the mitral valve prolapse with mitral regurgitation. And third differential will be the dilated cardiomyopathy. And the fourth is hypertrophic obstructive cardiomyopathy.
Oh, hypertrophic obstructive cardiomyopathy, I got a strong objection. Because at what age does hypertrophic obstructive cardiomyopathy start manifesting? At what
Be
age?
able to tell why you are considering these things. That also you should tell. Sir, questions asked, HOCM, your answer. Because when you are putting differential diagnosis, you have to say why you are presenting these differential diagnosis. Okay, that also should be there. Okay, sir. Sir is asking HOCM.
I am asking a question.
in third
Third
it
decade.
usually gives in third decade.
The HOCM starts manifesting at third decade. No, usually HOCM actually the hypertrophy pattern starts coming up during the growth spurt. It is during the growth spurt that hypertrophy start occurring, and the patient becomes symptomatic during the third, usually during by about in the third decade. So at this age, hypertrophic obstructive cardiomyopathy manifesting is a bit unusual. And one more thing I want to ask about the student who has discussed this case. The patient is not having paroxysmal nocturnal dyspnea, and he has got significant symptoms, no paroxysmal nocturnal dyspnea. So other than mitral stenosis, do you think that this patient can have something else which might have contributed to lack of paroxysmal nocturnal dyspnea as an important symptom?
Involvement of other valve lesion like aortic regurgitations.
No, aortic regurgitation will not reduce the symptom of
PND.
paroxysmal dyspnea. It may actually even aggravate.
In the differential diagnosis, it should be compatible. HCM, I may not be happy to entertain because there are no symptoms or findings or family history to diagnose HCM in a young person at age of. So you can say that if there was no history of rheumatic fever, if there is no history of rheumatic fever, what are the things you will consider when you get a person at the age of 14 years developing symptom of exercise?
So there is a warning
Rheumatic thing.
coming.
Yeah.
The
See, I
warning
think
coming
Yes.
from the evaluation that we have
I'll
already
take only
exceeded.
half a minute. I'll take only
okay.
half a minute, Dr. Venu. There is,
I have all,
if I am
yeah,
asked a
please.
differential diagnosis, because there is a history of rheumatic fever, I will go for valvular heart disease. If it is not rheumatic, again, mitral disease should be considered because it is very common. The second I will consider will be a congenital heart disease in a 14-year-old boy presenting with symptom of congenital heart disease. The congenital heart disease which can become symptomatic in the second decade. This is a shunt lesion which has developed pulmonary arterial hypertension. That will be my second possibility if there is no history of rheumatic fever. That will be then HOCM I may not entertain. Dilated cardiomyopathy or LB myocardial disease, okay, low in the list. That will be the way I will discuss. Okay, Dr. Venu.
Okay, I think now can we go to the physical exam?
Physical findings, yeah. I think we'll go to physical findings.
Coming to the general physical examination, patient is moderately built and moderately nourished. He is conscious, coherent, and cooperative. Weight is 72 kgs and height is 166 centimeters. And BMI was 26.6 kg per meter square. There is no signs of pallor, icterus, cyanosis, clubbing, lymphadenopathy, and pedal edema. Pulse was 88 beats per minute, regular, high volume, rapid rising and collapsing in nature. There is no radio-radial or radio-femoral delay. There is no vessel wall thickening. All peripheral pulses were felt equally. Blood pressure was upper limb, right upper limb 140 by 60 mm Hg and left upper limb 130 by 60 mm Hg. The lower limb is 205, systolic is 205 mm Hg and left lower limb is 200 mm Hg. Coming to the JVP, the JVP was 4 centimeters above sternal angle. A wave was normal. There is prominent V wave with normal respiratory variation. Abdominal jugular reflex was negative. Coming to the peripheral signs of AR, pulse pressure was 80 mm Hg and Durosis sign is present at the femoral artery. Trop sign is present. Hill sign is present, which is 65 mm Hg.
The discussing one question discussing group from the so far. Do you think that you would like to move away from rheumatic fever and think of something?
Yeah,
At this stage?
bicuspid aortic valve.
Yeah.
Mixomatous
I think,
degeneration,
yeah, I think you have to,
Marfan syndrome, aortic rare.
yeah, I think you have to think of other causes of severe aortic regurgitation, because aortic valve can be involved, but severe aortic regurgitation developing at this age in rheumatic fever, I would like to think twice before diagnosing rheumatic fever as the cause for severe aortic regurgitation. The patient, he might have gone to a doctor and he might have had some joint symptoms, and doctor might have detected the aortic regurgitation murmur, and he might have definitely diagnosed a rheumatic fever without doing any other tests. We do not know whether any proper tests have been done, and then only he has come to a proper conclusion. So
Yeah,
when
it's a very important point what Dr. Manjunath is saying. So you must start your examination with some signs of Marfans. You should do height, weight, and you should give upper segment, lower segment. That you should not forget,
Yes.
especially when there is a pure aortic regurgitation.
Some comments about your findings. Can you go to the previous slide? This peripheral sign, JVP. Okay. Next slide. Next slide. Next. Yes. You should get away from JVP at the earliest. Okay. 4 centimeters above sternal angle at postgraduate level. The question is it elevated or not? That's my
JVP
question.
not elevated, sir, normal.
Then it's better to say the root of the neck. That is a postgraduate level days. It is not elevated jugular. Then you said V wave is prominent. Be careful. Because normally A is more prominent than the V. Here you say V wave is prominent and you have to talk about the descent also. Postgraduate, you have to, because in a patient with aortic regurgitation or aortic runoff, you have got a prominent V wave. Because I am deviating. What is the condition where you get aortic runoff with a prominent V wave? Can you tell the answer? Any of your colleagues? There is a large volume coming to the right atrium.
Yeah.
You have to think of something else. Because normally, I'm not giving you the clue, it may not be, but prominent A wave means that runoff is coming to the right atrium also. So that you should be careful. Normally, A is prominent. We have said B is prominent, and why doesn't you didn't mention? If it is valvular heart disease, we are going for TR. Then we are deviating a lot. Okay, abdominal jugular reflex, negative, no, it is normal. You know what is negative abdominal jugular reflex? What is these things you should get away. You compress the abdomen, sustained compression, the JVP goes up and it should fall in a few cardiac cycles. The fall is more important because the right ventricle should handle that large volume. Where it is negative, so it is normal, it is abnormal,
Non-sustained.
or negative
Non-sustained.
means it is not rising. Vena cava obstruction. The jugular venous column is not rising with the abdominal compression. So these are some of the points. Go ahead.
now
So
what
be
are
careful,
the
JVP.
what are the causes of prominent V wave in the jugular venous pulsation? Can you tell about 4 or 5 causes for a prominent V wave in the jugular venous pulsation?
It's the tricuspid regurgitation, sir.
Yes, that's the most important. Very good.
Right. And if RSOV to RA.
Very good. RSOV to RA. Very good.
RA, sir. And then
prominent V wave in jugular venous pulsation causes.
So the pressure is coming from aorta or from the left ventricle?
When it comes from the left ventricle, can there be a reason for a prominent V wave?
Gerbo.
Yes, there's a
LV to
LV
RA.
shunt. LV RA shunt, yes. What else?
Indirectly?
Any other condition? Primary ostium primary defect, where there can be mitral regurgitation with atrioseptal defect. The jet can be towards the right atrium, and you can very prominent V waves. And finally, sometimes in patients with coronary cameral fistula, you can also get sometimes a prominent V wave. So when you described a prominent V wave, you should have an explanation why the V wave is prominent.
Yes, sir.
And also, as Sudhema rightly pointed out, when you are describing a prominent V wave, you should comment about the X descent, Y descent also.
Y descent.
Y descent. And
Yes,
what is the situation where Y can be very shallow or slow descent?
Shallow to tricuspid stenosis, sir.
Yeah, patients with tricuspid stenosis can have a very slow or slow wide descent. Okay.
Even in obstructive lesion like severe pulmonary arterial hypertension, not necessary that it should be only at the tricuspid valve. It can be at the pulmonary valve also.
And whenever there is a significant
No. Sir, I am not happy with that. He is telling that slow wide descent can occur in pulmonary stenosis. I am not sure. He has to explain that.
Not pulmonary stenosis, pulmonary arterial hypertension.
You have to explain that. Pulmonary hypertension without a TR, why should there be a sharp wide descent? I am not sure. Anybody can teach me. I have not thought about that. Pulmonary hypertension producing a slow wide descent.
No, I can think of his explanation maybe that if the patient is developing a severe right ventricular hypertrophy and there is a problem of relaxation, then the wide descent may not sharp as it should be.
I don't know,
that the
sir. Okay,
explanation, Balajan?
Fine.
Actually,
but be careful, sir. Be careful.
Okay, go ahead. The presenter can continue the presentation.
Yeah.
Coming to the examination of cardiovascular system, on inspection, chest is symmetrical and trachea is in central. Transverse diameter is more than anteroposterior diameter. There is no precordial bulge is seen. Apical impulse is seen in left 6 intercostal space, 2 centimeters.
See, here you are having a one controversial statement. You said no precordial, you are saying precordial bulge. All right, okay. Precordial bulge is a different thing. Okay, go ahead.
But postgraduate level, as Balandan sir initially said, you need not split into significant palpation. Don't use these subtitles. Just to present like that, chest is symmetric. Then transverse diameter you have measured fine. Sir, there is no precordial prominence. Apex beat is seen and felt. So you can summarize this. Am I right, sir?
Yes.
Yeah, rather than putting inspection, palpation, percussion, put it continuously. Chest is symmetric. There is no chest deformity. The apex beat is seen and felt in the sixth left intercostal space. Lateral temporal. What is the character? Nithral.
But
so like that you can proceed.
I would feel that either they can present as separate headings or they can combine inspection and palpation together.
Yeah, that will be better.
That can be done because many things that you get in palpation and in inspection, you will definitely have to present again in palpation. So
That's
rather than making it two headings, you can do inspection and palpation.
That's right. Okay, go ahead.
There are visible pulsations are seen in suprasternal area. There are no scars visible. On palpation, trachea is in central. Apex beat.
If you want to comment, how can you say that it is in the sixth intercostal space during inspection?
That's the same problem we said.
So that is why it is better to combine it. Apical impulse seen in the left sixth intercostal space. How can you be certain it is the sixth intercostal space? And 2 centimeters lateral to the midclavicular. All those things create a confusion. So better to put it as inspection palpation together. Okay, go ahead.
That's why Balendra sir initially itself said postgraduates, it should be more precise rather than an MBBS level of presentation. Okay, but it should be very clear. You cannot miss anything. Okay, because our aim is there cardiomegaly? What is the left ventricle like? What is the right ventricle like? What is the pulmonary artery size and pressure? What is the aorta like? You get a clear picture of the radiological anatomy of the heart. So that is what we want in inspection palpation. Percussion, we are not very much bothered. For namesake, you can complete it. Okay, go ahead.
Apex beat is felt in the left sixth intercostal space, 2 centimeters lateral to the midclavicular line, occupying 2 intercostal spaces. Hyperdynamic in nature, which was localized with medial retraction. Systolic thrill is present at the apex, and there is grade 2 parasternal heave is present. There is no palpable epigastric pulsations are present.
Are you sure that there is a systolic thrill at apex? Are you sure that whether there is a systolic thrill at apex?
Yes.
Because systolic thrill at apex is a very, very unusual phenomenon. It can happen in only very few conditions. And mitral regurgitation, usually there is no systolic thrill at apex. Because what is the mechanism of a thrill? Why there is a thrill?
When there is a turbulence across the valve.
Yeah, but not across the valve. There is a turbulent flow that generates the thrill. So yes, for a thrill to be palpated, a turbulent jet should come anteriorly. From
Yes,
a posterior structure to anterior structure, the only that can give rise to a thrill. In mitral regurgitation, where is the abnormal jet?
Posterior.
Towards
Left
posterior.
ventricle,
it
quite
can be towards
posteriorly.
Towards.
Sometimes you can get a thrill in the posterior aspect, but very unusual to get a thrill in a patient with mitral regurgitation at the apex. When you palpate the apex and getting a thrill is a bit unusual. If there is a thrill, I would still start thinking whether it could be an apical VSD. An apical VSD can have a thrill at the apex.
yes,
Bit unusual, because the thrill is because of a turbulent flow, and the turbulent flow should be directed anteriorly. So, okay, go ahead.
Can you explain it in this case if it is MR? Can you explain MR in this case can be very loud, can have a thrill. Even the sir said that point is well accepted. Can you explain? If there is MR, usually you won't get a thrill. In this case, you are expecting or you can explain because the LV systolic pressure is very high. So the LV-LA gradient is very high. In contrast to the usual MR, this is the way I may try to explain to give an information to the examiner that I know a better hemodynamics. Okay, but sir point is very well has to be taken. That is depends on the this thing. If it is rheumatic MR, where will you expect the thrill? That is what sir is asking. Next, go ahead.
On percussion, left second intercostal space was resonant to percussion, and left heart border corresponds to apex. Right heart border was substernal. Upper border of liver dullness was felt in right fifth intercostal space in the mid-clavicular line. Coming to the auscultation, S1 is soft, S2 is single, A2 is absent, P2 normal, hard at which was hard at pulmonary area. LV-S3 was hard at apex, LV apex, no opening snap. There is grade 4 by 6 high-pitched blowing pansystolic murmur, best hard at the apex with diaphragm of the stethoscope radiating to the axilla with breath held in expiration, increasing with the isometric hand grip and decreasing with Valsalva manual. Grade 3 by 4 high-pitched blowing end diastolic murmur, long murmur with
Early diastolic, not end diastolic, early diastolic.
Early diastolic murmur, with long murmur with duration more than 2/3 of the diastole, hollow diastolic, decrescendo murmur, best hard in left third intercostal space at the end of expiration with patient in sitting and leaning forward with the diaphragm of the stethoscope increased with squatting and hand grip. A short mid-diastolic murmur is hard at apex with no presystolic accentuation. A systolic murmur of grade 3 by 6 with early peaking hard in right second intercostal space with no radiation to the carotids. Coming to the
Other
respiratory
systems
system,
normal.
normal.
So we
Okay,
come back to
so
the auscultation. The previous slides. Previous. Okay. Fine.
what
He
will
said
happen to
A2 is
yeah, go ahead.
he said A2 is absent. When you say second zone is single, how can you say A2 is absent? Now, what is the likely cause of single second zone, or what are the factors which modify the split of the second zone in this case? What are the factors influencing the split of the second zone in this case?
ejection time,
Delayed closure of the.
In this case, your
No, see,
diagnosis obviously
See,
AR and MR.
you've got MR.
Yes.
patient has
So
got
with that, how do you explain a single A2?
this patient has got two dominant lesions or significant lesions. One is aortic regurgitation and mitral regurgitation. What is the effect of these lesions on A2? What happens in mitral regurgitation A2? What happens to
LV ejection time will be decreased, sir. LV ejection time will be decreased in MR so that A2 will be before itself, sir. So it will be widening in MR only.
Okay,
Okay.
what is the effect of aortic regurgitation on A2?
In aortic regurgitation, there will be no ejection time won't be prolonged, sir. So there will be normal splitting only.
No.
Oh, that is not the reason. No, wrong.
What determines the split normally? What is the important factor that determines the normal split? It is the
Yes, respiratory
hangout interval. It is a
hangout interval.
hangout interval. So now take that point and discuss.
Yeah.
Yes.
So here, in a patient with aortic regurgitation, A2 is it early, late, or remain the same?
Yes, sir.
It will be
You
delayed.
can take the clue from Sudhaymar said hangout interval. So what happens to the hangout interval of the aortic valve in aortic regurgitation?
What is
It
the
gets
SVR?
shortened.
Eh?
SVR
SVR decreases.
SVR.
Decreases.
So what happens?
SVR in AR, in high output states, the blood should flow to the periphery.
Yes, sir.
Should not leak back. So that the vessel should dilate. The SVR
Dilate.
should come down.
Yes, sir.
Okay.
So what happens to the hangout interval of the aortic valve?
Sir, LV to IO.
It decreases.
A2 is getting delayed. So
Yes.
in an
A2 is
aortic
getting delayed and there will
regurgitation,
be a decreased hangout intervals.
so there is
Increased hangout interval.
Increased hangout.
Because the SVR is coming down, the hangout interval on the aortic side also increases. So that the A2 is delayed. So there are three factors. One is the MR causing early A2, AR causing delayed A2 due to the low hangout the long hangout interval and increased ejection time. Third is the pliability of the AV valve, aortic valve. If the aortic
Yes,
valve
sir.
is grossly damaged, it may not produce a sound. If it is a non-valvular AR, it will be non-valvular AR, the A2 can be loud. So many factors can influence the second sound in this case. Then there is no RV failure, so that the P2 may not be modified. There is no PA, so P2 may not be modified.
Since S2 is single, obviously it means that aortic regurgitation is a more dominant lesion. Because if it was mitral regurgitation, I would have expected a wide split second heart sound. So here it is a single second heart sound indicating that aortic regurgitation of the two lesions, aortic regurgitation is more dominant, and S2 is A2 must be sitting on. So A2 may be sitting on P2 occurring together. How will you make out A2 is there or not? You should auscultate the aortic area. The P2 is not audible in the aortic area, but A2 can be audible both in the aortic area as well as in the pulmonary area. So if when you auscultate the aortic area, if you are hearing a second heart sound, that should be aortic second heart sound. So you should have carefully looked for the audibility of the second heart sound in the aortic area, and that would tell you that A2 is still there. So you have not done that. You should do that before you make.
Similarly, you inch your stethoscope from the second right intercostal space to the second. See, the new Hurst, which has come out, says you start your auscultation from the second right intercostal space because it gives straight away the A2 component. So that's an important thing to remember, that you go to the second right intercostal space, come to the second left intercostal space, and go down to the apex. Normally, P2 is not heard at the apex, except in pulmonary arterial hypertension, and that
Loud.
also with normal pulmonary artery pressures in ASD. In ASD, it can be heard.
No,
The
the P2 can be heard at the apex when the apex is formed by the right ventricle.
right ventricle. That's
where the in ASD there can be significantly dilated RV which will form the apex, and then you can hear the P2
without
at the apex.
PH.
So what you hear at the apex is almost always A2.
In this case, your absence of sec A2 can be explained because if it is rheumatic, severe AR, the aortic valve is grossly damaged and you may not hear the A2. But you can't tell that it is absent when you are presenting. You say, sir, second sound is single and normal intensity. If
And
it
you
is
should have,
single and normal
go ahead, Sudhama.
single and normal intensity in the pulmonary area, it is likely to be only P2. Because if you get single second sound, it will be either P2 or combined, it is a combined A2 P2. So if it is a combined A2 P2, it should be on the louder side. If you find a single second sound which is of normal intensity, it is likely to be normal P2. But these are very hair splitting. But don't straight away say A2 is absent.
And he could have also made a statement that what is the auscultatory finding in the second left intercostal space and right intercostal space. That will definitely help you to make out what would be the nature of the A2. And if the second sound is audible well in the right intercostal space, I think A2 is well audible. So that is a one important differentiating point, that A2 can be audible both in the left and the right intercostal space, while P2 is audible only in the left intercostal space, not on the right second intercostal space. What about the LVS3?
Next slide. Okay, fine. I think more
Yes,
than two-thirds of diastolic and holodiastolic, you cannot see. You can say it's a pan-diastolic or a holodiastolic murmur. Okay, fine. I think
Oh,
there is
yeah.
nothing much in the presentation. Okay, mid-diastolic murmur is heard with no presystolic accentuation, not that, with no presystolic component. It is confined to mid-diastolic. If you think it is MR, you can say there is a short mid-diastolic murmur confined to mid-diastolic. And usually, is it what will be the shape of that mid-diastolic murmur? If it is a flow rumble of MR versus flow rumble or functional murmur of AR. Flow rumble of MR is usually mid-diastolic and decrescent down because rapid flow comes down. Whereas flow murmur or the Austin Flynn murmur is mid-diastolic, it can have a presystolic accentuation because there is a premature closure of the mitral valve or a diastolic MR also. So that is the difference between the flow murmur of mitral regurgitation versus Austin Flynn murmur. Actually, Austin Flynn originally described presystolic murmur.
Yes.
So the mitral regurgitation flow murmur or any flow murmur due to post-tricuspid shunts or whatever it is confined to mid-diastole and it is decrescent. No presystolic component. Austin murmur can have a presystolic component also other than mitral stenosis. Okay.
As Slemmer rightly said, Austin Flint initially described the murmur as a presystolic murmur. And the explanation that he offered us, what was his explanation?
Severe air jet, which causes the fluttering of
No.
AML leaflet.
Now there are many explanations, but
originally it was what?
it was
Aortic
thought to
jet
be due to
striking the AML and lifting it to a
premature closure of
mitral.
And
so you
the
say that endostolic
associated
closure or
the premature closure of the mitral valve with probable diastolic mitral regurgitation may be the mechanism of Austin Flynn murmur. There are now many mechanisms described for Austin Flynn murmur. Can you enumerate one, two or three? What are the mechanisms of Austin Flynn murmur? Balasubramaniam or Anil Kumar. Anil Kumar should answer. Anil Kumar, what are the different mechanisms of Austin Flynn murmur?
So low frequency sounds transmitted to the apex.
No. That's not correct. I don't agree. What are the mechanisms of the production of Austin Flynn murmur in severe free aortic regurgitation? Fluttering of the anterior mitral leaflet, especially when the regurgitant jet comes and strikes the anterior mitral leaflet. You can see fluttering movement of the anterior mitral leaflet. Two, the jet can partially close the anterior mitral leaflet. That can result in something like a relative stenosis can give rise to a diastolic rumble. There can be a diastolic mitral regurgitation. And finally, two jets are coming to the left ventricle, one from the left atrium, other from the aorta. When they come together and collide, that can give rise to turbulence and give rise to a diastolic rumble. So that by means of which my Austin Flynn murmur can be explained. And what are the one or two important points by which you will differentiate Austin Flynn murmur from mitral stenosis murmur?
Sir, presence of openings.
One is the hand grip, sir. Hand grip, when we do hand grip, AR murmur will be increasing, sir. But the MR, there won't be any change.
Murmur also can sometimes increase because
because
it can also increase. But
yes,
most important thing I usually take students is that you must look at the S1. S1, if it is loud, you should always think of the possibility of associated mitral stenosis. In
yes,
patients with severe aortic regurgitation, usually S1 will be feeble. Then, of course, there are few other points like pre-systolic accentuation, opening step, but are less important points. But I would recommend always look for S1. Even a patient with aortic regurgitation, S1 is loud. Always think of the possibility of associated stenosis. Okay, go ahead.
Coming to
Okay,
the
clinical diagnosis.
valvular heart disease, severe aortic regurgitation with severe mitral regurgitation, probably rheumatic etiology with no signs of pulmonary venous hypertension, with mild pulmonary arterial hypertension in sinus rhythm, NYHA class 3 with congestive cardiac failure with normal LV function, with no evidence of rheumatic activity or with no evidence of infective endocarditis.
You have to explain everything.
Now, I would like to know.
Statement.
Oh, yeah.
Sir.
See.
Yeah, I would like to have an explanation on severe mitral regurgitation. The first one I accept. Severe aortic regurgitation can, with the florid peripheral signs, I also agree that there is severe aortic regurgitation. And also, there is a ejection system, early peaking ejection systolic murmur that definitely goes in for severe aortic regurgitation. But I would like to know, how did you diagnose severe mitral regurgitation? Because this patient is, second sound is single, there is no wide splitting of second heart sound. I would like to know, why did you diagnose severe mitral regurgitation?
There is LVS3, sir.
LVS3 and MDM can occur in severe AR. What is the
Severe
significance of S3 in AR? May indicate LV dysfunction. So that doesn't help us. So it is extremely difficult to say assess the severity of MR. Second, why did you say probable rheumatic etiology? We have some other DD in a young person with history suggestive of rheumatic wear and double valve lesion in the absence of Marfan syndrome. Why do you say probable? You can avoid such statements. No signs of pulmonary venous hypertension, but mild pulmonary hypertension. Without pulmonary venous hypertension, how can they have pulmonary arterial hypertension? And second, what is the evidence of PH as per your clinical findings? Your second sound is split and normal P2, you said. So what is the evidence of mild PH? You said grade 2 parasol heave. I want to ask a question. And a medial retraction. Non-compatible statements are there. We are teaching you that you should be careful. That you said that apex is this thing and there is a medial retraction. Along with that, you said there is a grade 2 parasol heave. The second sound is normal and you're saying PAH without pulmonary venous hypertension. So if that is the situation, what is the type of pulmonary arterial hypertension? It has to be precapillary. So these are the conflicting statements which you have made. We are not criticizing you, but be careful. You are benign, we have presented it, but these are areas where we have to be a little more careful. Okay, fine.
And one more question.
These are my comments about that.
One question you have said about severe mitral regurgitation, and a few points which we have already discussed, like wide splitting of second heart sound, is not there. But one additional finding that if you have looked for, and then I would have been happy. So what is the thing which you would look at in a patient with mitral regurgitation for assessing the severity? You can look for the left atrial pulsations. How can you look at the left atrial pulsations? Where do you look for left atrial pulsations?
It's a left sternal border.
Sternal border has got. Where do you look for the left atrial pulsations?
Left lower sternal borders.
Left lower sternal borders. Where is what is the pulsation that you felt in the that you feel in the left lower? Where? Where? I'm not the timing. I'm asking where. It's felt in the third left intercostal space. It is the third. See, the second intercostal space, you get the pulmonary artery pulsations. Third intercostal space, you can feel two pulsations. What are those two?
Sir,
one is the
RVH and left atrial.
Which one?
Sir, right ventricular hypertrophy and
which part of the right ventricle?
Infundibular part.
Infundibular part.
Yes, RV outflow and the LA pulsations can be felt. And third and the fifth, fourth and the fifth intercostal space, you can palpate the body of the right ventricle.
Where do you see the inflow of the right ventricle?
Inflow.
Inflow
Okay.
of the right ventricle is?
Fourth and the fifth intercostal space. Okay. Shall we go for investigations?
Yes.
Shall I add a little more on that point? Second space, it is the pulmonary artery. Third space is the RVOT. Laterally, it is the L post diuta. If there is an L post diuta, you get laterally, you get the aortic pulsations. Then third and fourth space, a little laterally will be the left atrial expansion. Then lower down is the parasternal heave of RVH. Left atrial expansion, people say it is late systolic. Somebody said that. I may ask a question why it is late systolic. You find out the answer and tell later. Okay, why it is late systolic? Well, regurgitation is maximum in the early systolic, and there is isometric, no isometric contraction phase. People have taught you. People are going on repeating. Manjaran sir or Balendran sir, can you explain this late systolic? Because I could not, because there is no isometric contraction phase. And the regurgitation is maximum in the early phase. Why it is late systolic? Everybody teaches them. Any explanation, sir?
No, only explanation I can offer is that in the early part of the systole, there is a left atrial relaxation. And then when there is a left atrial relaxation, pulsation transmitted may not be that prominent. And when the relaxation is over, you get the prominent left atrial pulsation. That can be the only explanation. But I don't teach that there is a slightly delay. RV pulsations, the left atrial pulsations are slightly delayed.
Actually,
maybe because it has to be transmitted.
I think, okay, that we'll discuss later, sir.
Okay,
among
go
us,
ahead.
because it
the late
occurs in the
systolic,
CV.
the late systolic pulsation is because the LA dilates, presses the RV. It is the RV actually which gives the pulsation, not the LA proper.
RV outflow, RV outflow.
Outflow.
It pushes the RV.
RV. And that only you can feel, because the LA is a posterior structure. You can't feel that.
The only question is why it is late. I am concerned about the timing. Forget about that, sir. Next.
Late,
next
rather than late, it would be maybe slightly delayed compared.
That's why they describe it as squid effect. Squid effect. Which
forget about that, sir. Investigations.
Okay. Investigations, ECG, X-ray. Which investigation would you prefer? Whether ECG or X-ray? What do you think? Which one will you prefer? Which one?
To tell that answer, you should know what you are expecting in ECG, what you are expecting in X-ray, how to differentiate these two lesions and severity. Then it is simple to answer that question.
Here there is a problem. You want to differentiate of the two lesions which is more severe. So for that, is X-ray more useful or ECG more useful?
X-ray.
X-ray.
X-ray. Oh, why X-ray is more useful? Why X-ray is more useful? Which is a chamber which can be dilated in a patient with mitral regurgitation, which will not be dilated in a patient with aortic regurgitation.
Left atrium.
Can you look at the ECG and tell us whether AR is dominant or MR is dominant by looking at the precordial leads?
I also want to ask that question from the electrocardiogram. Do you think which is dominant? That's sir's question. Am I right, sir?
Yes.
AR is dominant. Deep S wave is seen in V1s.
Pardon?
Deep S wave is seen in V1s.
Okay, voltage.
That
voltage, in which condition it is more? Which condition will have a larger diastolic volume? Voltage is related to the diastolic volume. So which condition will have a larger diastolic volume?
Yes.
That you should answer very fast.
Yes.
Yeah.
Yeah, but that also depends upon what is the more severe lesion. So patients with mild aortic regurgitation and severe mitral regurgitation can have a different volume. The volume by itself may not help you, but I fully agree with you that if the patient is having some degree, see one difference between the in severe MR, it is purely left ventricular volume overload. While in aortic,
sir, urge point not for controversy. In severe MR, because the ejection fraction is
That's right.
more,
Yes.
the end-systolic volume is less. So even if there is a large volume, the end-diastolic volume seldom goes beyond 55. Whereas in AR, which has the larger volume, so that larger QRS potential is seen more in severe AR than in severe MR. In severe
And
MR, when
also,
they're going for LV dysfunction, the voltage may increase. That's my concept. You may be right, sir. Okay.
now I want to add to that. So in patients with MR, it's a purely volume overload, while aortic regurgitation is actually volume overload plus some degree of pressure
sir.
overload, because they can have a higher systolic blood pressure. So the hypertrophy pattern will be more pronounced in aortic regurgitation than in mitral regurgitation.
What is
So
the
with this
ECG sign of?
electrocardiogram, what do you think? Is it more likely to be AR severe or MR severe?
MR severe.
Simple. Definitely AR is severe because the pulse pressure is high 200.
He said MR severe.
The voltages are very marked, sir, in V5, V6.
Yeah,
very
but
tall.
I think he said mitral regurgitation is more severe.
That's
what I
okay. We need not debate on that. We need not debate on that.
What is the ECG's evidence of acute left ventricular dilatation?
Another point, one important point in the electrocardiogram that you can look at is left atrial enlargement. In patients with mitral regurgitation, the left atrium will be definitely dilated, especially with a severe MR. But in aortic regurgitation, left atrium is protected. It is separated from the lesion, and the left atrial enlargement may not happen unless the patient has started developing severe left ventricular failure. So here if the left atrium is not dilated, obviously means that it's more likely to be aortic regurgitation.
Dr. Bala was asking a question. What is it?
What is the side of LV dilatation on the ECG?
Left ventricle.
So normally the voltage in V5 and V6, if you compare, V5 will be more than V6. The T wave height will be more than V5 will be more than V6. But if in V6 it's more than V5, it's a sign that the left ventricle has dilated.
About deep Q waves also, sir.
Deep Q waves. Yes. Deep Q waves.
Deep narrow Q waves in V5, V6, more than 4 millimeters, also occurs when there is a volume load.
So volume overload, that is a differentiating point between volume overload and pressure overload. Can you tell quickly 1 or 2 points to differentiate the volume overload as against the pressure overload of the left ventricle?
Pressure overload, there will be ST depressions with T-wave inversions, like strain pattern. There will be no strain pattern.
What will happen to the QRS morphology?
QRS will be.
QRS, what will happen to duration? What will happen to the height?
Height will be more, sir, in pressure.
No.
Oh, in pressure overload, height will be more. Then, if you look at the muscle mass, which condition has got more muscle mass? Is the pressure overload or volume overload?
Pressure overload.
Pressure load, you are right.
No, usually it is in volume overload, because volume overload is a large size, and even the thickness of the myocardium is not more. If you look at the total size of the myocardium, it is in volume overload that you have got more myocardial size compared to the pressure overload. That is why you get a very tall R waves in volume overload, but in pressure overload you don't get that tall R waves. You can get a slightly broader QRS complex in volume overload, in pressure overload, but in volume overload, it will be narrow QRS complex. Okay, so
that question a postgrad should answer like that. Is it a concentric hypertrophy? Is it an eccentric hypertrophy? Is it a concentric remodeling, eccentric remodeling? That is a postgraduate level of answering. That is the muscle mass versus the volume. That determines. In aortic regurgitation, it is a concentric remodeling where the volume is more, the muscle mass is more. So, as sir said earlier, the potentials will be large. In pure aortic stenosis, it is concentric hypertrophy where the muscle mass is more, but the volume is small. So, the R wave height is determined by the cavity diameter, which is the Brody's effect. So, in aortic stenosis, the muscle mass is more, so the QRS becomes a little wider there will be some degree of fibrosis so that the septal Q will be lost and the amplitude will not be great. And in combined lesion, you will find the combination of both. If you get a very tall R wave with STT changes, it is a combination.
Yes.
Unless the STT changes are contributed by so many other factors. Okay.
But,
sir.
I thought, Sudhemar, I could with you that if you look at the total muscle mass, it is in volume overload, you have got the total muscle mass rather than.
Agreed, sir.
Agreed.
But you
Agreed,
look
sir.
at the
Agreed.
thick.
Agreed.
Right. Okay, go
Agreed.
ahead.
Agreed, sir.
Exercise, let's go.
I was just adding the other terminologies also for the postgraduate to read.
That's right. Okay.
The
Is there a
extent-
left? Is there a significant? Does this X-ray suggest or vital regurgitation?
Or do
So
you
there is
want to say the severity of the two lesions after the X-ray and the ECG?
Is there a huge left atrial enlargement?
yes.
Where is the huge left atrial enlargement? I can't see that.
What is the degree of left atrial enlargement in the right border? The right border, the left atrium can be seen, but it is well within the right atrial margin. So it's only a grade 1 LA enlargement. The left
And
bronchus is
also,
not significantly elevated.
and
So
also
the LA enlargement is marginal.
and
Am I,
also the
sir?
left atrial
Am I
appendage
right,
is.
sir?
Yeah.
Yes, I agree with you. Left atrial appendage is not significantly dilated. So the various features by means of which we diagnose left atrial enlargement, it is minimal. So left atrium is not grossly enlarged. So by looking at the extended ECG, which is the dominant lesion.
But the carina also is not that much wide.
Aortic
Okay.
But what
regurgitation.
about the
Okay,
left?
go.
What about the left ventricle? Do you think this left ventricle is not enough with your clinical diagnosis of very severe AR? What is the cardiac
No,
size in severe AR radiologically? It may not be because the left ventricle is enlarging posteriorly also.
Yes.
So the radiological LV enlargement, we may underassess in LV enlargement because enlarges posteriorly and laterally.
And
Whereas
also
right
sometimes
ventricle enlarges laterally. So cardiomegaly in transverse diameter is more appreciable in RV volume overload than in LV volume overload. This is all relative. This is all a theory, but not to make the final diagnosis.
And also in aortic regurgitation, in good X-ray chest, the LV may dip down there below the diaphragm, and sometimes the enlargement may be partly missed in the regular X-ray chest PA view because it can dip down. There is one condition where the LV can dip down and the enlargement can be sometimes as clear cut as you get in a patient with mitral regurgitation or where there is associated RV enlargement.
And how do you diagnose
Radiologically,
LV dilatation in lateral view?
oh, that is a criteria. We have to draw the lines in the lateral view. There are two lines, and there are certain indices also. You read up that because we are not routinely teaching
Doing.
that. I also have forgotten that.
Line he should
Now the
mention.
radiology.
He should understand where. How will you in a lateral view? How will you make out which is right atrium, right ventricle, left atrium, left ventricle? That you should mention. Where is the what is the line and how will you make out?
Can we go to the echocardiography?
Okay, right. You will go to the echo.
This radiology doesn't show pulmonary venous hypertension, doesn't show pulmonary hypertension. That also you have to tell.
Correct.
Echo.
Yes.
Okay.
Yes. We are running very fast. Okay. So there is significant severe
Go
AR,
on
there
reading.
is significant MR,
Go on
etiology.
reading.
Okay. It is too fast to read.
Go on reading. Anil Kumar, you go on reading. Why are you not commenting?
I think you start from the beginning because otherwise you're too fast.
Start from yes. Start from here.
Stop that. Somebody is operating. Stop at the other. Stop there and discuss. Yes. Let us phrase that. Okay.
Sir, there is restricted PML restriction is there and AML is doming, sir.
No,
It is
basically
not
you should
doming.
start with the
No.
chambers. What is
First,
the
you have
left
to tell
ventricle? What
about
is the left
the
atrium?
view
What is the
also.
aorta?
Left atrium was dilated and left ventricle also dilated, sir.
Then mitral valve, the morphology, because that comes in rheumatic heart disease. What is the echocardiographic features? These are the questions that will be asked of acute rheumatic pericarditis versus the chronic rheumatic heart disease. What are the changes you expect in chronic and acute? These things you should read. Acute rheumatic fever, the echocardiographic criteria for diagnosing aortic valvulitis and rheumatic mitral valvulitis, and chronic rheumatic heart disease. This you should read.
And
Okay, go
also
ahead.
chronic mitral regurgitation, how will you think that this is a chronic rheumatic mitral regurgitation and not something else?
There's thickening of the valves, sir.
Yeah, the PML, the valves are thickened, the subvalvular apparatus also thickened, coda can be thickened, and then the PML is fixed and thickened, and the direction of the jet is
Sir, eccentric
PM.
jet. Eccentric jet.
In what is the direction?
So towards the
Posterior.
Is
posterior.
it posterior? Yes, the jet is posterolateral. The jet is posterolateral jet. That is the classical direction of the jet of mitral rheumatic etiology. And if there is a PML prolapse, it is when anterior jet. So the direction of the jet also will give you a clue to the etiology of mitral regurgitation. Okay, go ahead. We have to come to the diagnosis and management. What are the points by which you assess the severity of mitral
See, there is
regurgitation?
a incomplete aortic leaflet closure also here. So that could explain the A2, which is very soft.
Go ahead, quick. No, parasternal long axis view you should
Yes, sir.
image for aortic regurgitation.
Yes, sir.
Why
This
the
is
aortic regurgitation is not imaged in parasternal long axis view?
It was there in the second frame, sir.
Second frame.
It was there in the, after that 2D,
Yeah.
in the second frame, it
Yeah,
was
this
there
one.
in the parasam.
This one, yeah.
Oh, right, yes, okay.
That's it.
But it is too much colorful, so it is okay.
The
How
LA
severe
size
is
is, compared to the radiological, the LA size seems to be larger than what
Larger.
we saw in the
Yes,
X-ray. Am I
correct.
right, sir?
Yes.
Yeah, I agree with you then, because here
Yes.
the left atrium seems to be dilated, while in the X-ray test I found it extremely difficult to make out a significantly dilated left atrium.
And what you have to do is we have to read all the echocardiographic parameters of assessment of severity of AR and MR. I
Yes,
think we need not teach you now.
yes. I think that's
Because
all. That's the most important.
Venu is very harshly looking at us.
No,
Because we have only 6 minutes.
You have another 5 minutes.
Yeah.
There's a
Okay.
Francis, if you
I think you should discuss what the management also.
Yeah, now
that's
you will
right.
have to go to the management. I think that's the most important thing. I think, can you shortly discuss the management?
Sir, patient is
Chronic
symptomatic.
rheumatic heart disease, severe MR, severe AR. You should have put severe AR, severe MR, dilated LVLV, moderate TR, mild PH. Are we mild PH because the TR jet gradient was, what was the TR jet gradient? RV systolic pressure 31 plus RA pressure. I don't know whether you can
Yeah.
call it as, because there the question comes, how to diagnose PAH by echocardiogram in a borderline RV systolic pressure
Systolic
calculator,
pressure.
because 31 plus 5 will be 36. I think that may not be enough. Am I right, sir?
Correct.
They may not be enough to say unless there are other features of RVH. That is,
Confirm.
you have to
No.
look for other features of, am I right?
Yes.
Because you
Yeah,
cannot
I
diagnose.
think. No, but if the TR wedge velocity is more than 2.83, I think we'll have to presume that there is some degree of pulmonary artery hypertension. What is the TR jet velocity? What is the TR velocity? Peak velocity?
Sir, if it is 3, it will be 36. So it
Yeah.
is less than 3 here.
2.83,
So if it is
2.85 will be
83, maybe around that. Because if it is equal to or more than 3, you can say. But in such cases, there should be other evidences of right ventricular hypertrophy. Okay, sir. Fine.
How will you assess the right atrial pressure? Anil Kumar. See, Sudhimar said +5. I am saying it is +15. How will you assess?
What will you use to get the RA?
Inferior vena cava, collapsing of the inferior vena cava.
Yes. So if the inferior vena cava is distended and non-collapsible, it is about 15. If it is totally collapsed, it is 0 to 3. When it is normal, then it will be anywhere between 3 to 10. So by looking at the vena cava in IVC pressure pattern, we'll be able to assess the right atrial pressure. So I come to the management.
One more question. How do you assess the LV function from a MR jet? Can you assess LV function from an MR jet?
DT, sir.
DP or DT, yeah. How do you assess that? How do you
DP
look
by
for
DT, it is a negative DP by DT
Negative
because
by
it is
DT.
coming
Negative.
down.
Correct.
Negative DP by DT.
how will you assess the DP by DT?
Sir, we have to put a continuous Doppler at mitral valve, sir, and then at 1 meter per second and at 3 meter
3
per
meters.
second, we have to measure
Correct.
the slope, sir.
Measure the slope at 1 meter per second and 3 meters per second. Then what do you do next?
And
DT. Now you have got the DP.
Do you get a DT?
What is the DT part of it?
Anil Kumar.
2 minutes, sir.
Time taken for the MR slope to reach, sir.
Yeah.
MR to reach its peak.
Time to peak.
You
to
look
peak
at
in
the
MR.
you look at the time taken for the pressure to rise from what to what? 1 meter to
3 meters.
3 meters.
3 meters.
Okay.
One more point I will add on that. The PEP by LVT can be taken and measured. Am I right, sir?
Yes.
The pre-ejection period to the LVT.
Correct.
Okay, that you have to take. That will be much less in mitral regurgitation. Normal PEP by LVET indicates LV dysfunction. Am I right, sir?
Yes.
Yes. Okay.
Okay,
Now
go ahead.
management.
Sir, patient is symptomatic and severe MR and severe AR is there, belongs to the class D, sir. He requires double valve replacement.
Right.
What
But
is
you should say, sir. But you should say, sir, this patient requires rheumatic fever prophylaxis. This patient requires medical management. Stabilize the patient, evaluate in detail, and consider double valve replacement. That is the thing. And which valve will you prefer? I will prefer mechanical processes. Am I right, Atraile, sir? That's all what we have to tell.
Mechanical process is young, so we have to go for the mechanical process. Now, I would like to know what you mean by afterload mismatch, whether there can be afterload mismatch in this patient. What is meant by afterload mismatch, and can this patient have afterload mismatch? Kumar, where are you?
If there is a delay, that means they don't know the answer. We can teach them.
Yes.
When a patient with mitral regurgitation is a situation where there is offloading of the afterload of left ventricle, because left ventricle can easily pump to the low pressure left atrium. When you replace the valve with when you replace the regurgitant mitral regurgitation, that facility where LV can pump to a low pressure zone is taken away. It has to pump against the systemic vascular resistance. And when some of these patients may not be able to handle the systemic vascular resistance, and they go for heart failure. So that is not.
Can I have a final question?
Last question.
What is the rheumatic fever prophylaxis you are going to give? That's my final question. Half a minute. The rheumatic fever prophylaxis you are going to give.
Sir, lifelong prophylaxis, sir.
Okay, data. You are quoting the WHO, Indian or the American?
Indian.
Indian. Lifelong is debatable. You have to say that this patient requires parenteral penicillin prophylaxis once in 3 weeks, because this is a high risk case, minimum up to the age of 40 years, maybe lifelong. Okay, fine.
Okay.
Now, if I'm asking a theoretical question. Once you replace the mitral aortic, why do you want to give penicillin prophylaxis?
Sir,
If the patient in acute rheumatic fever, myocardium is not involved, only the structure which is involved is the valve. And you are replaced two valves which can be affected in acute rheumatic fever. And you are
right.
replaced, then why do you want to give prophylaxis? It's a challenging question.
And now pancreatitis.
No,
No.
there is sufficient evidence that acute rheumatic fever, there is no myocarditis. A good paper has come out from Only Institute. They have done a biopsy of the biopsy in patients with acute rheumatic fever, and they found there is no evidence of myocarditis.
Myocarditis. Yeah.
And also, yeah, and there is no, and also a good study has come from South Africa, where they thought that patients with acute rheumatic fever, heart failure is because of the acute mitral regurgitation, and they replaced the valve in patients with acute rheumatic fever, and all of them recovered. So the myocardial factor is being questioned. And so the only organ which can be affected is endocardium, and it is the valve which is affected.
This patient belongs to juvenile rheumatic fever, 19 years of age. So presentation previously was all mitral stenosis, but here we have two regurgitant lesions. This is also not uncommon that you have MR and AR without significant mitral stenosis.
Aortic regurgitation, such severe aortic regurgitation in acute rheumatic fever, I'm a little surprised. I would like to inspect the, if the patient is undergoing surgery, I would like to inspect the aortic valve, whether there is any other pathology there or not. It's only to keep my mind open, because
Mitral valve
such
is rheumatic.
yeah,
The
there's no
mitral
doubt.
valve, that is
I
rheumatic.
agree. But I see, because the aortic regurgitation is so severe in acute rheumatic fever, and over a period of 3 years becoming so severe aortic regurgitation, bit unlikely. So I would like to keep my mind open about the pathology of the aortic regurgitation. Okay, I think that is all. I think we'll hand over to Venu.
Thank you, sir. It's a very good case and excellent discussion. I think must have been very beneficial for the postgraduates. A lot of points have been covered. Over to Arun for further comments and conclusions.
Thank you, sir. I should thank the students of both teams and all the examiners for having such a wonderful discussion. I think it's a privilege for us to listen to this discussion where I hope the students have also learned as much as we learned throughout, because you must and we must appreciate the pains that these examiners are taking to listen to each and every line or sentence that you are telling, and then correcting each step. So I think, I don't know if it's very difficult to get examiners like this to go step by step these days. I think hats off to all the examiners, Majiran sir, Sudhema sir, Bharendra sir, and Vanajaksha ma'am has been very silent, but ma'am has also been there. Thank you, ma'am, for being there, and good presentation by Dr. Anil Kumar, well discussed by the student fan from Madras Medical College, Dr. Bala, Dr. Shumar, and Dr. Prema Vasan. We were fortunate to have Dr. Shashank Sinha presenting live from the United States, on behalf of the Heart Failure Society of America. We are fortunate to, this association has tied up with Heart Failure Association of India for some time now, and this session has been going on for some time. We will get back to the, on the next month for the next edition of this Heart Failure Masterclass. Thank you once again. And on the night when the India and Pakistan have decided on a ceasefire, we've had excellent academics, and thank you everyone once again. And let's keep learning, and I think make clinical medicine be in good state. Thank you.
Thank you, the Art Failure Society of India. And I think I must thank on behalf of myself as well as all the examiners that it is an honor to be a part of the clinical discussion of Art Failure Association of India, and I enjoyed it thoroughly from beginning to end. And of course, it is a treat to be along with Sudhir Kumar and Balachandran to be the examiner. I think it's a treat. We can have a lot of newer ideas in clinical medicine, and it's going to be a wonderful discussion.
So they,
So on behalf of all the
Extremely
students in Madras
sorry
Medical
that,
College, we sincerely thank from the bottom of my heart. Thank you so much for the
I'm
opportunity
sorry
given,
that
sir.
we could not hear from Madam Vanidakshi Amma. We're extremely sorry, Madam. We could not we just could not see you. And one interesting thing was from the chat box, come on, Bala, come on, Bala. Then I was thinking, is it addressed to Bala, sir? Then only I realized that there was a Bala student also. Just cheering up, come on, Bala, come on, Bala, come on, Bala. It's a great pleasure to be with Bala, sir. Manjuran, sir, we usually have interactive sessions. Bala, sir, after a long time we are saying thank you, Arun, and the whole team for giving us the chance to interact with all these people. Thank you so much. And the students have done really well.
Yeah. I must thank Venu sir, Chopra sir, Harish
Thank you so
sir,
much.
Dr. Sajan, and Sun Pharma, and everyone who's worked behind in the Heart Failure Association of India and the Heart Failure Masterclass for giving us this opportunity time and again to learn. Thank you.
Actually, we learn a lot from this discussion. That is the interesting part. Thank you.
I think every day there is a learning process, and by discussing, we always learn from each other. I think that's the way we can progress.
Good night.
Good night,
Good
and
night.
thank you.
Good night.
Thank you. Good night.